Good morning and welcome to this morning's discussion of Psyfeld. Today's episode will be the shower head. So where does the group want to start this morning? Any character, any scene? Any observations? Any of the interns can unmute. Tell us where to start this morning. No wrong answer, I promise you. How about pick a character and tell me one thing about them? Start it real easy.
Let's start with Elaine.
Elaine.
With the like opium or opioids coming up in her blood test.
All right, so we have a character that tests positive for opioids. So she has to provide a urine. There's a trip to Africa. Unfortunately, her urine drug screen comes back positive and it tests positive for opioids. So signs and symptoms of opioid intoxication. Anyone?
Sedation, slow, frustrating.
That's the biggie. Okay, so the pupils are something that's going to come up in your shelf exam. All right, so slurred speech, decreased or depressed respirations, level of consciousness, certainly even coma if overdose, right? So the reason why we have to, pardon the pun, focus on the pupils is because I would say 40% of the time or lower, they will be pinpoint. But pinpoint pupils actually are a necessary criterion to diagnose intoxication or overdose from opioids. So how is it then that the majority of the time, I'm going to say 60+%, the patient on your shelf exam is going to present with dilated pupils? And the answer is because there's a medication that when either used, abused, or overdosed on actually has a contrary effect on the pupils, and the patient presents with dilated pupils, not pinpoint. And the board wants you to be able to identify that. So I'm going to say greater than 50% of the time, 60+. You're going to actually see dilated pupils. The board is going to help you look right past it. That can't be opioid intoxication. Good, it is. For what medication? What opioid? Good, right? Meperidine has a side effect that is anticholinergic, and the anticholinergic side effect, can be anticholinergic, right? No, cholinergic side effect, excuse me, that will actually override the opioid effect and result with dilated, not constricted pupils. So something to pay attention to. And I think that's the medication, that's the presentation that does appear on shelf exams quite frequently. All right, so you've identified opioid intoxication, opioid overdose. If you miss this, admit a patient into the hospital for pneumonia, etc., they may go into opioid withdrawal. So give me the signs and symptoms of opioid withdrawal. What will withdrawal from opioids, meperidine or others, look like?
Nausea, vomiting, sweating profusely, diarrhea.
Right. All the above, right? So it looks like the flu. Okay. Any presentation of the flu on a psych shelf is opioid withdrawal until proven otherwise, right? Exactly like the flu, right? So body aches, etc. The acronym is TGI Fridays. Now, you will not need to know the required number of criteria to rule in, especially on a shelf exam. I mean, very rarely will you. This is not one of those cases. However, in the acronym, T does stand for 3. I've got to use it, otherwise we've got to change the name to GI Fridays, doesn't quite fit. GI, you said, nausea, vomiting, diarrhea. In clinical practice, nausea, vomiting, versus diarrhea, two separate criteria. So if your patient is vomiting and has diarrhea, you count that as twice, right? Shelf exam, it's not going to matter as long as you identify GI. Fridays, fever, rhinorrhea, insomnia, dysphoria, arthralgias, yawning, and then sympathetic symptoms, goose flesh, diaphoresis, elevated blood pressure pulse. Right? TGI Fridays, need 3 of them.
So I have a question.
Yeah.
Is it the history or is it the fact that opioid withdrawal is more severe that will allow you to tell the difference between them on each other on a top exam with SSRI withdrawal?
So,
I feel like a lot of
yeah.
the view world is like nausea, vomiting, dysphoria, like that kind of stuff. Is it just one's more severe?
No, I don't think one is more severe than the other. I mean, when you have the shorter half-life opioid withdrawal severe, it's not life-threatening, but it could be very severe. It's very uncomfortable, no doubt about it. The shorter half-life agents in both respects are what's most concerning. So paroxetine, very short half-life agent, much more likely poses significantly more risk for SSRI discontinuation syndrome than the longer-acting SSRIs, fluoxetine, norfluoxetine, which is the primary breakdown product of fluoxetine or Prozac, has a half-life measured in weeks, like 5 weeks, right? So much less likely to go into the SSRI discontinuation syndrome with fluoxetine versus paroxetine. The other one that is notorious for inducing the SSRI withdrawal syndrome, because it's such a short half-life, is Effexor, venlafaxine. So those are the 2 that usually appear on shelf exams, right? So they require a taper, so at least 2 weeks, at least 2 weeks. Now, for the SSRI withdrawal syndrome, there's additional signs and symptoms that you just don't see in opioid withdrawal. And the one that is common, and therefore the one that presents commonly on shelf exams, is that feeling of an electrical impulse or discharge. People who suffer from this may actually feel like they're being shocked, especially in the lower extremities. Right? You're not going to see that in opioid withdrawal. But then again, the history is significant, right? Most definitely. The history of any kind of drug use, SSRI versus opioids, prescribed or recreational, certainly differentiates. Any other questions about opioid withdrawal? How do you treat it? So I'm going to answer my own question because I want to make sure I guide this correctly in kind of an outline form. Do you treat it with substitution therapy? Do you treat it with symptomatic therapy? Or do you treat it with both? Sometimes you're right, but it's both. So you can't be wrong. For milder withdrawal states, choice B, symptomatic therapy only, absolutely. Right? You can get by without that substitution therapy for milder withdrawal states. But especially on a CL service, apply both. Recommend both. So symptomatic treatment lists about 7, perhaps 8 medications that addresses each specific TGI Fridays, with the exception of the 2. So patient has a symptom, you provide them a PRN med, symptomatic relief, often referred to as the COWS, C-O-W-S protocol. So when you hear COWS protocol, that usually means that the individual is being provided symptomatic relief for the individual or specific withdrawal symptoms. In combination with that, you can also provide substitution therapy. Generally speaking, this form of therapy is when we provide a medication, a drug, with the same mechanism of action as the drug of abuse, but with a longer half-life. So we substitute methadone or buprenorphine for heroin. Because of the interaction at the mu opioid receptor, the individual is not going to experience withdrawal when prescribed correctly. Usually, there is a number of bags that equates to a milligram dosage of methadone to ballpark this. Usually we start off about 30 milligrams of methadone as a test dose, but there is some quantification where if your patient does endorse X number of bags, it means that there's a certain number of milligrams of methadone that you should consider increasing from 30. Right? I'll get to that conversion. All right, so you want to put them on both. Methadone, buprenorphine. What is Suboxone then? Right.
Um,
Go ahead.
buprenorphine plus naloxone.
Right. So here we have buprenorphine, which is that partial mu opioid receptor agonist combined with naloxone, which is a mu opioid receptor antagonist. So it's a partial agonist slash antagonist combination pill. Not the best to use for substitution therapy because even though in theory the naloxone is inactive, it still is active to some extent. So you can precipitate a more severe withdrawal state. That's why it's better to use either buprenorphine or methadone, the pure mu receptor antagonist. In the case of Suboxone, the partial, right? A partial antagonist differs from a full antagonist in that it binds to the same exact receptor, specifically the mu opioid receptor, if I can say it, but only activates it a certain percentage, whereas a full agonist, such as methadone, will fully activate 100%. All right, so you get your patient through the withdrawal phase. You get Elaine through her withdrawal phase. And now you want to provide and discuss with her a biopsychosocial outpatient treatment plan. So there is no further evidence of opioid withdrawal. We are discharging her from our hospital. Now she's following up with you. What do you want to discuss with her about your treatment plan?
If we're going to put on the Suboxone, everything that patient given to her, and then also recommended probably looking at first if she's amenable to it, like an intensive outpatient. If that's something she's going to do, so she'll first follow up. And then maybe perhaps weekly after that, when she feels ready to have it down on, and if she more so prefers groups and you can with the research.
Good, good. So just a review for those on the other side that may not have fully heard. Biopsychosocial treatment plan should focus, of course, on the bio. And one of the options under the bio division would be the prescribing of a medication called Suboxone. So now we're going to revert to the buprenorphine with the extra constituent of naloxone. The reason why here is because while inactive, and again, whatever activity this component may have is irrelevant because the patient is no longer in withdrawal. The opioids are out of her system. Fortunately, if this pill were crushed, it does activate the naloxone, meaning that you are preventing diversion. It's got very little street value as a result because you can't crush it, snort it, or shoot it. And so that's the reason why you're going to give a 30-day supply and have them follow up on a monthly basis, perhaps after an addiction IOP program, if not an inpatient rehab. Right? So level of care addressed and the bio of biopsychosocial addressed. Okay? In addition to this, it's probably important, as you had mentioned as well, to engage in groups and some kind of support. That's the psychosocial part of the biopsychosocial treatment plan. NA, 30 and 30, or I should say, I'm sorry, let's step that back, 90 and 90, so 90 meetings in 90 days. If NA isn't something that seems like a good fit, AA works just as well. Right, so work a program, informed consent, so you can speak to their sponsor. And I think that's the usual or routine evidence-based start of the outpatient treatment plan. Any other observations about Elaine? What happens when her urine comes back free of opioids. Towards the end of the episode.
I mean, I'm not sure this is really transfer off the punch and all that, so,
Why?
I think he was with her. Because he said she's going through menopause, and I don't know if he was suggesting that, it wasn't her urine by saying like, oh, here's you're like going through menopause and, like, you might have osteoporosis, so I'm not sure if it's like, to me, that's a suspicion that it actually wasn't her urine, so he's saying that.
I don't know if Peterman would actually know. My gut said that he in fact doesn't. But whether he does or not, he identifies that Elaine, of course, this not being Elaine's urine, it's Mrs. Costanza's, actually is in menopause and there's evidence of osteoporosis. For osteoporosis, when in the world would this come up for a psychiatrist other than routine health maintenance? Why would I bring up the O word in a didactic in the core psychiatry clerkship? Good. All right, so that's one. High risk for or in the patient population of anorexia nervosa. Yeah. And so something definitely to remember. Individuals with chronic malnutrition in general, and certainly, for example, in terms of a psychiatrist, anorexia nervosa are at risk because of the metabolic abnormalities of that eating disorder, of that chronic state of malnutrition. And one of the potential long-term sequelae could be osteoporosis. Right? So that's got to be part of your psychoeducation provided to individuals with eating disorders. Good. Is there another example you can give me? Again, another chronic mental disorder.
I don't know the exact relation between them, but I do know that there's been like some
Yeah, that's still in the non-clinical research kind of environment, and it gets at the hypothalamic pituitary axis, right, and the gonadotropes. Again, largely research, so not really that much impact yet for the clinician. About in psychotic disorders. What lends risk to osteoporosis in someone with a chronic psychotic disorder such as schizophrenia or schizoaffective disorder? Neither of which Mrs. Costanza had.
That's maybe like a little bit research, but if you're on chronic if you have some kind of blood medical, cortisol can.
You're exactly right. So the answer was chronic antipsychotic use. And I want to know a specific elevation, which comes up on shelf exams. So what's the M1 answer for how antipsychotics work? Decrease dopamine in the central nervous system, right? Now, when you decrease dopamine at the level of the mesolimbic tract, that's good news, because the excess of dopamine there results in the positive symptoms of schizophrenia, right? So that's the good news. So a person comes in and you've now increased that dopamine depleted state at the level of the mesolimbic tract, and the patient will manifest that as improved hallucinations, improved delusions, improvement in their disorganized thinking or speech, as well as improvement in their grossly disorganized or catatonic behavior, positive symptoms. Unfortunately, you can't just simply increase dopamine in one area of the brain and leave it alone in all the other areas. So you're going to get extrapyramidal effects. And one of those extrapyramidal effects, that is lowering dopamine in areas where it doesn't need to be lowered, is at the level of another tract called the what? Where else is dopamine synthesized? Exactly right. So the tuberoinfundibular tract, right? Lowering dopamine at the tuberoinfundibular tract results in the loss of that inhibition, and therefore the unmodulated prolactin release. And so hyperprolactinemia is a side effect of antipsychotic medications. Hyperprolactinemia, increased prolactin levels, because prolactin is usually inhibited by dopamine at the level of the tuberoinfundibular tract. By lowering dopamine there, you lose that inhibition. The net result is a hyperprolactin state. Patient comes in on an antipsychotic. You could fill in the blank, any antipsychotic here. We do not get routine lab assessment. We don't get monthly prolactin levels on our patients. We talk to our patients, and if they provide evidence of hyperprolactinemia, then we check a prolactin level. So, what will the patient tell you that will make you or result in your getting a prolactin level? So they definitely could have nipple discharge. Yep, right, galactorrhea. Very rare though. Rare too. Gynecomastia, yes, rare. Less than 10%. That's the one you have to ask, right? So for women suffering from schizophrenia on an antipsychotic, you have to ask when their last menstrual period is. And any amenorrhea should definitely have you think that this may be due to hyperprolactinemia as a side effect of your prescribed antipsychotic medication. Unfortunately, that probably is going to identify half your patients as the other half are males. That's it, right? That is the most common presenting complaint in males as a result of hyperprolactinemia. That's a decreased libido. You have to ask. Good. All right. So increased, and if you miss this, the chronic sequelae may include osteoporosis. Good. Let's move away from Elaine and Peterman. And any other characters catch your eye? Discussing the shower head.
They're just all a little suspicious for changing the shower head. Like initially, Kramer was like, "You need to change the shower head." Like he was a little bit paranoid about what was happening and what it was just happening to him. And they all moved over. Back to the shower head. Which also is not a conspiracy against them. Local shower heads.
And that happens kind of quickly. And again, I'm going to cheat. That happens often. I mean, we're talking about, episode 16, season 7. There are 9 seasons of this. And you can look at a lot of these characters and play roulette, and it goes from George to, in one episode, to Jerry in another, to Kramer in yet another. So we see this among this group of friends. And to the extent that it is pervasive, and it is stable over time, season 1 through the final season 9, that is consistent with what we would expect of a personality disorder. And therefore, it is consistent with what we would expect from the paranoid personality disorder. Now, I don't think I'm gonna just kind of fall short of diagnosing all 4 core characters with paranoid personality disorder, but it does conjure up that very conversation. The cluster A personality disorders, again, I think relatively adhere to a cardinal trait. You are 1 week away from your final exam here, your shelf exam. Take clusters A, B, and C. If you haven't done it already, toss them all into a hat and do a couple things. Number 1 is pull out the 3 cluster A personality disorders and convince yourself, at least for the next week, that they are not true personality disorders per se. Instead, they're prodromes to schizophrenia. Because if you study them in the context of schizophrenia, again, the causes of schizophrenia are biopsychosocial because the factors that predispose to any illness are always biopsychosocial. When you take the quote unquote psycho part of that out, there's 3 conditions you have to remember. That is the paranoid personality, schizoid, and schizotypal personality disorders, right? So remove them, discuss them, think through them, as a part of the schizophrenia spectrum. That only leaves you 7 personality disorders to remember for your shelf, the large majority of which adhere to a cardinal trait. So instead of thinking them along the lines of cluster B versus C, and you could even include cluster A in this discussion, there are really only 2 types of personality disorders, 2 revised clusters. Cluster A or cluster 1, just so there's no confusion. Cluster 1, where they adhere to a cardinal trait, and cluster 2, where they don't. Borderline personality disorder is the only one really in cluster 2. So if you remember or memorize the 9 cardinal traits, you're not going to miss a personality disorder question on a shelf exam. And we'll pull from paranoid personality as that example, a pervasive distrust or suspiciousness of others. All of the other diagnostic criteria then default to simple examples of that cardinal rule. You can't miss paranoid personality. What is the defense mechanism that is maladaptive in individuals with paranoid personality disorder? Avoidance, no, avoidance is avoidant personality disorder. Displacement, no, close though, projection, right? So an individual has an impulse, and we're going to talk about this at noon as well. The impulses lie in our id. They lie in that most animalistic part of who we are, right? The id is governed by the biological drives. So again, I'm kind of crisscrossing streams here. Freud with Maslow, right? If it's not eating, sleeping, or having sex, it's not the id. Right? That all id impulses for human beings cannot come to conscious awareness. They're taboo. And that aspect of ourselves, our personalities that ensure that, it's called a superego. So there's constant conflict between what we want to do. And if you ever want to understand what we want to do, safari, great adventure. Look at our ancestors and what they're doing any time of the day, anytime they want. And that's our id. We don't act like animals because of a formed, evolved cerebral cortex where our superego is localized, right? So it's a protective measure. Lose the cortex, lose cortical functioning, and you will behave like an animal. The cortex versus the subcortical structures, the superego versus the id, constant conflict. The ego has to mediate that conflict. That is the sole purpose of our ego, the third and final component, the referee. The way the ego does this is through these subconscious processes called ego defense mechanisms. Projection being one. The impulse, instead of saying, I hate them, I want to kill them, is turned around to its complete opposite, and it's reattributed to the other. So instead of me acknowledging I hate them, it's they hate me. I'm being persecuted. That is the core of the paranoid personality disorder, projection. Any other? We have a minute or two left. Any other observations from the shower head?
Just some kind of the reasons to drug-related behavior the shower had. Like for example, like when comes over to Elaine's house, like, oh, you're going with like the good stuff, and like I guess her boss like walks by and sees that. Even like when they were buying the shower heads, like the black market shower heads, and kind of like that. You might even get the drug situation with it.
Yeah, I completely agree. A very loose association to reach a teaching point, but a reminder. When you're thinking through a substance use disorder, and you can now just include any substance here, the definition, the actual diagnosis never has anything to do with frequency or quantity. So when you discuss that the patient's use of a drug, be it cocaine, be it caffeine, be it nicotine, doesn't matter, is problematic, maladaptive, and therefore should be the focus of clinical attention, what response you're often going to hear, perhaps as a result of other defense mechanisms, is, I don't drink every day. or it's only a couple of beers, or it's only a few glasses of wine with dinner. Quantification has nothing to do with the diagnosis. It's the maladaptive behaviors that result from one glass versus one case that cause clinically significant distress or impairment. So always try to refocus your patient on the level of distress it's causing them and or their social support system, their family. That's where the conversation has to go. And once they see the level of distress or impairment that it's causing, whether it's one glass or one case is absolutely irrelevant. We'll end it there. We're at the bottom of the hour. We'll be back at noon to discuss our films. Again, we'll be combining Abnormal Activity with Night's Watch. So we'll have two films in a single discussion. We'll see everybody back then. Thank you.